I'd like to welcome all of you to this workshop titled Wholeness in Brokenness Facing Non-Cure. When I was asked to present, I thought about someone that can be of great not only help, but someone that can lead in the workshop, someone that can that have experience, that can share with us about how we can be whole when there is brokenness in our lives. And I'd like to introduce my wife, Gloria Ceballos. My wife, Gloria, is a nurse. She has been working in nursing for quite a few years. I will not dare say how many years, because then she'll maybe a little upset with me, because people will begin to figure out how old she is. She's not. I have to tell you that one time I went to my travel agency, and she knew me because she had made a lot of arrangements for my travel. But she had never seen me. My secretary did all the arrangements. That was a long time ago. And one time I went to see her, and my wife had been there the day before or so. And when I went to see her, she looked at me, "Oh, you are Mario Ceballos. Your daughter was here yesterday." Gloria, as I said, is a nurse. We are the proud parents of one son. His name is Mario Antonio, and he is an attorney in the city of Orlando. Gloria was born in the city of New York. Her parents are from the beautiful island of Puerto Rico. We met in Puerto Rico when I was going to college there. Gloria has a college degree in nursing. Her master's from Andrews University is from nursing administration, and she has completed all the classes for her PhD, and she is in her final stages of collecting the data for her doctoral degree. And she has worked for many years as a hospital administrator. At the present time, she is the vice president for nursing at Laurel Regional Hospital, a hospital in the Maryland area. We do get to travel once in a while, and this was a wonderful opportunity for her to come with me. And I will ask her, Gloria, to come forward as I ask all of you to please bow your heads as we pray. Dear Heavenly Father, I ask you, Lord, to be with Gloria and with me as we discuss this important issue of while we are on this earth and we can be broken, how we can obtain wholeness. In the name of my Lord Jesus Christ, I pray. Amen. Gloria?
So welcome this afternoon. I was sitting here looking, not even looking back, I said, honey, nobody's going to come. It's Friday afternoon. We've had a long week. There's many people that still want to go and explore Prague who haven't had the opportunity. Probably people are tired, but I want to congratulate you for making the effort of coming to learn about wholeness and brokenness and to hear the presentation that we've prepared for you. I'd like to know who's in the audience. Do I have any physicians? Nurses? Great. Pastors? Okay. Any other healthcare providers? Probably, okay. Leaders in your churches? Yes. Welcome. We have prepared these objectives, and just to make sure you're in the right workshop. What we want to do is to help the participant understand what happens when non-cure happens, when that is the reality. But we're not going to focus only on death. We're going to also focus on healthcare issues, and we're going to focus on, for example, when there's a loss period, like of a job, because the strategies are the same. We're going to look and explore at stages and steps that people go through when they have a loss or when their wholeness is broken, and we will look at challenges, the challenges that people have in making choices before and after brokenness. We will also see how culture and faith influence or inform the choices and journeys taken by the different people who are experiencing this non-cure. But we're also going to explore strategies that as healthcare providers, as Seventh-day Adventists, as church members, what strategies what is our responsibility, and what things that we can do during this time that our members, ourselves, or somebody else in the community is experiencing loss. We're going to make this, I wanted to make this very practical. So we are going to have at least, depending on the time, and Mario is a great timekeeper because sometimes I get to talking and I forget about the time. But we're going to have some discussion because, again, being 2 o'clock in the afternoon, after lunch, after a long day, and after a long week, we want to make sure that that we can help each other stay awake. Now, do we have somebody translating? Okay. Okay. If I'm speaking too slow, please make a sign. I am? I'm speaking fast? No. Oh, okay. Then just make sure you make a sign so that I can slow down. Sometimes as a New Yorker, I speak very fast. People tell me I'm always speeding. If you ask my son, I speed at everything. So we will have some discussions where you will participate in identifying some of these strategies, and we're going to talk about some of the things that you can implement. So we'll start with a quick definition of curing, and you probably saw this yesterday at my husband's presentation, which is the focus of curing is to address the needs of the physical body and to relieve it of any discomfort, aches, and pains, symptoms, crises, and illness. It has little to do with treating the hidden contributors responsible for the formation of these effects. Chronic illnesses such as cardiovascular disease, cancer, diabetes are among the most prevalent and costly of all global health problems. And this is a quote from the World Health Organization. But also, how else can we be broken? We can be broken because we have broken relationships, and you will see this because we're human beings, we are of a broken nature, right, because of sin. So we have broken relationships, we have brokenness due to loss of loved ones. We also may be broken, we have loss of a job. We also may be broken because we have a tragedy, loss of body parts, and as we've seen in the world lately, this is of course, very present in our mind in the United States because of the bombing that we just had in Massachusetts. So cure, this is another slide that my husband had reviewed yesterday. And so cure really means relief of the disease or the condition. As a noun, you hear that there's a search for a cure for a common cold, so it's a treatment that cures disease. And also it's used as he was beyond cure. And those are the words we dread the most, right? This is beyond cure. So the first thing that happens is grieving.
What are the 5 stages of grief described by Elizabeth Kubler-Ross?
The 5 stages of grief described by my co-author, Elizabeth Kubler-Ross, are denial, anger, bargaining, depression, and acceptance. She first identified them in 1969 in her book on death and dying. And the stages have now become as legendary as she is, and they are very well known and commonly used by many people to identify milestones that we go through in grief. But as she always said, those stages are as individual as we are. We're all going to go through them in different ways. They don't have to be linear. You don't have to have 1 month for each stage. And some people may spend more time in anger and less time in depression, and they're very different. We always say one of the biggest misconceptions is that we have to follow the stages, where the truth is the stages reflect where we are. So just do your grieving, and you may notice from time to time, oh, I'm in that stage. But just know it's not a prescribed formula that you have to do. It just helps you normalize where you may be. And you may go through the stages more than once.
So the grieving process. For those of us that are in healthcare and healthcare providers, this is something that is in our training, right in the fundamentals of our training. I remember as a young student in the 1970s, as I was taking psychiatry nursing, Dr. Kubler-Ross's work was fresh. It was in the 1969, so it was in the 1973 that I was in nursing school. So it was fresh information for psychiatry and what was going on. And so I remember vividly looking at her research and hearing her speak. And so we'll go quickly through this grieving process for those of you that are not familiar with it. The first phase is denial. And as you heard her co-author, because there's much more research that has been done on the grieving process, and the gentleman that you saw is somebody that has expanded on the research. But the basic process is the same. It's based on the 5. Denial, when the patient is in state of shock or the person is in state of shock of denial, the person goes numb, wonders, how are we going to go beyond this? And so this can also happen not just from a loss because of a death or because we're sick and you were told, you know, you have cancer or multiple sclerosis or some other terrible disease. But this also happens sometimes just plain in loss of a job. We remember my husband's grandfather came to live with us at 91. And the reason why he came to live with us, because my husband was called, we lived in the United States. My husband is from Venezuela, and we were called from Venezuela. And his friend told him, Mario, you have to come for your grandfather. And why? Well, your grandfather, we retire him and we say goodbye to him on Friday, and he shows up to work on Monday again. And so at 90, he was still working. He was still working in the sugar cane factories, right, where they process sugar cane up in the mountains in Venezuela. And he was an engineer. And he's the one that arranged and built all the machines that would squeeze the sugar out of the sugar cane and the juice. And he felt so close to that. And although he was 90, he showed up every day, Monday morning, ready to work. But we knew that at 90, his eyesight was failing, and he was in danger of falling and maybe having hurting himself. He did live with us 8 years after that, but he was in denial. He thought he could still work. After he came with us, he was 95 years old. We brought him even here to Paris because he was born in Martinique, and he traveled to Paris with us, and we showed him around Paris, and one of his sisters was alive in Paris, and we went to visit her. And his mind was all there. But I tell you this because he kept books. He kept books of his engineering tutoring. He was tutored by Englishmen. And he said, when I go back to work, I need to review, because when I go back to work, now he was 91 and 95 when he came to Europe. So denial. We can be in denial that something's happening. And then the second stage that Dr. Kubler-Ross studied and discovered was anger. And anger is necessary because of healing process. And you have to be willing to feel the anger. And as we've heard through all the wonderful presentations, you need to be able to, this is normal, you're going to feel anger, and you need to be able to name it, right? As we saw the physician present yesterday, and I forgot his name, when we can't identify those feelings, it's going to be harder for us to go through this process. And as we heard the speaker, the video, it's not linear. You don't go through the process all the same. Some people go 1, 2, 3, 4, 5. Some people go back to denial after anger. Some people after anger, may accept everything. So anger. I think some of the personality traits also figure into anger. I would probably think that I'm a very choleric person, sanguine choleric, but I can tell you my anger would be I would be very demonstrative in my anger because of my personality traits. Some people, hold anger inside, won't talk about it, and will probably act anger in many different ways. So bargaining is the third phase, and bargaining is just, Lord, take this away from me. Take this away from me. What can I do? I will eat vegetarian the rest of my life, or I will drink my water, or, as we see people that don't have faith, they do extraordinary promises, right? They say, I will, walk the street, on my knees, or up the stairs to the cathedral, and so that's where bargaining comes in, thinking that maybe just something is not going to be real. The third is depression. The fourth is depression. This is, of course, empty feeling. The patients or the people that are experiencing loss will go into deep depression. Again, some people severe that they can't even get out of bed. And some people just that they stay away from their friends, from church, from coming to meetings. So these are things you can watch for in your congregation, in your groups, because when somebody is depressed, they just fall in this stage and they just think it's never going to end. And the last one is acceptance. That's the fifth one. But acceptance is often confused with the notion of being okay. Acceptance doesn't mean that says, oh, okay, I'm okay now. I denied, I was angry, I was depressed. Now I'm just going to accept it. No, acceptance means that they've accepted the fact that they have cancer. Let's say if that's the loss. That doesn't necessarily mean they've accepted the fact that they're going to die, right? So acceptance varies in what the loss is. Now we see this in many ways. I wanted to also tell you that we have, where I work, we have a unit, a hospital ward, where we have patients that have been through maybe an accident or a tragic accident, or somebody has suffered a gunshot wound, that are on ventilators. So they are breathing with a machine, and that's their chronic state. We call it the chronic unit. And these patients sometimes come to us, and we're able to extubate them and take the trach out, and sometimes this is the way they're going to live. Just a couple of weeks ago, we had a family come that the mother, who was 70 years old and took care of the grandchildren and took care of everybody, she was a great-grandmother, she had 7 children. She just was shopping and she just dropped. She just dropped. She had a level 4 intracranial bleeding. And so that means, the brain is pretty much gone. So, but they took her to the hospital, they revived her. Now she's breathing. They told the family she's not going to live. She's not going to live. But you know what? The lady lived. So then they told them, she's going to live, but she's not going to come off the ventilator. She's going to have to breathe with this ventilator the rest of her life. And she's probably, she's still going to die. Don't expect her to go through much longer. Well, 4 weeks later, she was alive. She was, of course, in coma because her brain, was almost all gone, but she was still breathing. They were able to take the ventilator off, and she was breathing on her own. Okay. So at that point in the United States, we don't keep you in the hospital. At that point, we bring you to another level because there's nothing else we can do for you. But now we're going to maintain you or take care of you until you die. So the family was very, very angry, very angry. They expected her to live when they came to us, to our hospital, from a big hospital, George Washington Hospital in D.C. That's a big Georgetown hospital. And they came to our hospital just because it was the next level for her then to go to a nursing home. And she was unconscious, but she had a tracheostomy, and she was not going to come out of that state. And the family, we as healthcare providers had to really work with the family. They were angry, they were crying, they were in there, and they were in there 24 hours a day. There was somebody with her. They were all taking notes as to what the caregivers were doing or not doing. Were they pulling on her? Were they turning her? Were they cleaning her face? Were they bathing her? And it was very, very difficult for the caregivers to deal with this. That's what happens when families are not accepting and they're dealing with anger. These are 7 stages, and we're not going to go through these. This is just, I wanted to show that there's continuing to be a research done on the 5 stages that Dr. Kubler-Ross originally talked about in 1969. But as you can see, it's just basically adding to the 5 stages that she first discovered. Now, so we're past the shock. What happens then? The reality is that there's many things going while these stages are happening. There's still adjustment that has to be made, because now that you have a diagnosis, now that you have a loss, you're still going through this grieving process. You're still broken, but there's a lot of things that still have to take place. You have to keep on living, right? Some have to keep on living. So we're going to talk about self-management. And you're wondering, why in the world is she putting self-management in this presentation? Well, the research on self-management comes from nursing. And how do you manage these things really are not coming from physicians. And that's why I asked if any physicians are here, because I don't want to offend them. But most of the research is done on self-management, or on how people respond to illness, is done by nurses in the United States, because the definition of the American Nurses Association for the American nurses, part of the definition says that it's the alleviation of suffering through the diagnosis and the treatment of human responses to illness. That's the definition of nursing. And so if nurses take care of the human response to the illness and the treatment, that's what nursing is. Physicians diagnose, right, and treat the disease. Now comes the nurses who coordinate how that patient is responding to this illness that's being treated. So what nurses do then is that nurses now increasingly have been doing qualitative research, from where empirical questions then come to be studied. And so nurses started to look at self-management, and self-management is the dynamic, interactive, and daily process in which individuals engage to manage chronic illness and loss. Different than self-care. As you can see, self-care is just when you self-care, you want to be healthy, so you make sure you have the right diet, you exercise, you take care of your health in every which way that you know. But self-management happens when you really have brokenness, and now you have to manage it, and how you as a person are going to handle that. The optimal self-management entails the ability to monitor the illness and to develop and use cognitive, behavioral, and emotional strategies to maintain a satisfactory quality of life. Now, when I was studying nursing, I didn't even think of cancer patients living longer than a few months, right? And actually we have, I'm looking at a sister here, that we have something happening right here within your group, that we have somebody that just 10 days ago was diagnosed and died. But on the other hand, cancer has become, as you saw in the World Health Organization statistic that I gave earlier, has become a chronic illness. I know people that are living with cancer and they're 5 years, 10 years out. I know people that have gone through two transplants because of cancer and have lived 15, 16 years. Personally, I know them. I also know, a nurse that is now 20 years out after being treated for ovarian cancer twice. Now, we know that ovarian cancer is one of the deadliest cancers in women. And, but it's now considered a chronic disease. People go to work with cancer. So how do we then self-manage? Corbin and Strauss were the nurses that first identified the processes of self-management. And as you can see, that's recent research in 1988. And they identified 3 tasks of self-management. They said that in self-management, the person, first takes care of the medical piece, make sure they go to the doctor and they take their medicines, and then they change their behavior to self-manage, and they also manage their emotions. They take care of, what is it that they're feeling as they're going through this grieving process that we're talking about. But more recent research, actually in 2012, Schulman is a nurse, and she and a group of nurses studied over 250 research studies that have been done on self-management, collected all this data, did a meta-synthesis of the information of all this research, and what they just identified last year were that there's 3 other focuses on categories of self-management. The first category is focusing on the illness needs. The second is activating resources, and the third is living with chronic illness. Now, the reason why I'm putting this in this workshop is because as you recognize this, as you see this, each of these have areas where you as healthcare providers, pastors, churches, health ministers can incorporate strategies for you to help people. Because as you identify where people are in your churches or yourself in any of these categories, there's strategies that you can do to reach them, right? And to, again, present and help them through these chronic illnesses. So the first one is focusing on illnesses. Focusing on the illness. These are tasks necessary for taking care of their bodies and their illness-specific concerns. That's the first thing they do when they say, okay, so you're going to live with cancer, or you're going to live with multiple sclerosis, or you're going to live with diabetes, okay? And, there's still, as we know through some of the presentations we've had, diabetes is now considered a curable disease, right? Because of, if you follow everything, it could be, you can live free of diabetes. Most people don't. Most people with diabetes live in a chronic state, have to take insulin, have to watch their diets, and go through the brokenness of losing maybe their eyesight, maybe losing limbs, etc. So, but they learn about it. They also learn about the regimens. When do I have to take the medication? So, as a multiple sclerosis patient, those of you that know people with multiple sclerosis, as you know, it's a debilitating, slowly debilitating disease that you can live for a long time. And multiple sclerosis is a disease that pretty much, in layman's terms, your spinal cord starts disappearing, or it starts shrinking, or you start losing the functions of your body. And multiple sclerosis is very impacted by stress. So these patients have to take steroids. They have a lot of steroids to take. And they also have to learn how to control the areas where they go to, because if the stress goes up, they immediately start either tingling, they can immediately start feeling their body impact of the disease. During this state also, during this characteristic, they deal with how to go on living without being fully healthy with the terminal disease or the loss, because they're focusing on it. And this research found that in focusing on illness, it's very important for them to keep appointments, and they also become experts. So they may be just focusing on this. So you were just diagnosed with some disease. With our friend that we know, this patient that I'm talking about that lived over 15 years, with the first diagnosis he had was leukemia. You want to talk about Paul? Paul.
Paul actually was the husband of my secretary. So it was 15 years before his death. As I was getting ready to preach, she comes up and she says, Mario, Paul has been diagnosed with leukemia. And they were giving him basically a couple of years. But both of them became so interested in the disease, they began to find out anything about the disease. He actually had a sister, and the sister came in and donated bone marrow, and he lasted 15 years, and he went through several of those. But they all became very interested. I had another friend, a pastor, and this pastor was diagnosed with prostate cancer when he was 51 years old, and he was given 5 months to live. And again, he became an expert in colon cancer. You know how old he was when he died? Prostate cancer, I'm sorry. You know how old he was when he died? He was about 67 years old when he died. I remember because one time as a chaplain, I was asked to go and see him because he was having a discussion with his new physician. The physician came in, and when he looked at the PSA, one of the indicators, usually supposed to be like 2 or 3, very low. He had a PSA of about 400 or something like that. And the fight that he had with the physician is that what the physician wanted to do, as he explained to me, he says, Mario, all I want to do is to insert a tube in his bag to go into what used to be his kidney, and now it's just a little sac with urine inside. And I just want to drain the urine. But he was so involved, he allowed the physicians to do almost anything. He went out and looked at all natural remedies. He took every single natural remedy that he could find. When he was about 60 years old, when he came to church, he preached. And you could smell a little bit the urine. He had a swimming pool. He had his little bag with him all the time. But he was so interested in the disease, he became an expert. And he was able to last that long.
And sometimes they become so experts that they come with all the papers now with the internet to the physician's office or to the hospital with all the work that they have found, right? Focusing on illness. The next one is activating the resources. Is the next characteristics they found on self-management. Resources that are integral to optimum health management, as you can see here, are family and friends, healthcare providers, spiritual resources, social services. They also activate resources in the community health services. It includes the spiritual resources, social transportation services. In this stage, when the person is dealing with their chronic illness, they also interact with processes in which individuals vary in their ability or willingness to take a role in managing their illness. You know, they go back and forth. Oh, no, I'm just going to have my wife do the injection. You know, my wife only can do the injection. I'm not going to do the injection. And, or they take full responsibility and they're going to say, you know, I'm going to learn this. I'm going to take care of it. I'm going to inject my insulin myself, or, you know, or my vitamin daily, or my whatever it is that they have to give themselves. But also, the activating resource, it's a personal process that can vary over time and depending on the resources. But as people are active in self-management, what they'll do is they will plan. And as we see later on with coping and healing, what they do is that they plan, let's say a person that knows that it's a terminal illness like multiple sclerosis or cancer, because I just don't want people to think that you only die of cancer. Although my husband says we all have a terminal disease. It's called sin, right? We're all going to die. But the person, what they do is that they plan for the future. Like, when I stop walking, you know, I'm going to work till I have to be bedridden, right? So that means that they're going to work while they are using maybe crutches, right? Or then they can't use crutches anymore. I'm going to work wherever I can go with a wheelchair. And then they plan for, I'm going to work, you know, from home. And then I'm going to, so they plan. And so at these different stages, they have different needs, don't they? So what you can do with crutches is different than what you can do from home.
Don't go too far. I just cannot resist the temptation. There is a book. It is in English. I don't know if it's in other languages. And it's called Tuesdays with Maury. Tuesdays with Maury. And it's a story about this man that had a terminal disease. And a friend with him that was a journalist was visiting him, or began to visiting him every Tuesday. And they began to talk about his disease. And he used to say this, and forgive me, I will try to do it in a way that will not offend anyone, but he used to say this: I know when I will lose my dignity. And it's about planning for the future. And the journalist asked him, and tell me, when do you know that you are going to lose your dignity? And his expression was this: I lose my dignity when I will not be able to wipe myself anymore. In other words, when I go to the bathroom and someone has to clean me because I cannot physically do it, that's when I will lose my dignity. But he was planning even for that time when his disease was going to deteriorate in a way that there were very private things that he would not be able to do anymore.
So coping, and you know, we heard a story right now of coping. You know, how did she cope through not only living with cancer, she's living with a chronic illness, and also living through burning of her home when she was in communion. So, you know, sometimes people say, how can that happen? You know, how can a pastor die young? Or how can somebody at communion? People that don't understand the conflict we're in the world. And that's why we have to take this message, that this, you know, God does not cause this. God does not cause the illness. Evil does, right? Evil. It's because of sin. So coping and hope have a dynamic relationship in which each supports and in turn is supported by the other. So here we're going to be studying about coping and hope, and how we live with brokenness is through coping and hope. So coping refers to the thoughts and behaviors people use to manage the internal and external demands of a stressful event. And coping is problem-focused, right? Because you have to look at gathering information and making decisions. It's how you start coping. It's also focused on emotions. You know, sometimes coping with something means that somebody will run away, will get away, will not see their friends, or they stop seeing somebody to cope with what they're going through at the moment. And coping also is emotion-focused, is seeking for help emotionally to handle the stress, the anger, the feelings that are coming out through the serious situation. And also coping is meaning-focused. In other words, what does it all mean to us? It regulates, meaning regulates the positiveness in coping. If you have meaning, then you will manage it positively.
I was visiting a patient in the emergency room. She was in her late 70s, maybe early 80s. And the doctors needed to put a pacemaker. And she looked at me and she said, "But chaplain, why a pacemaker? Why am I living? There is no reason for living." And we kept on talking, and I asked her, and this is some of the things that some of the techniques that you may be able, more than techniques, some of the different things you can do to people, helping understand what is meaning. I asked her, "Are you living alone?" "Yes, I'm living alone. My husband died. So there is no one in this world to be with you." "Well, I have 3 grandchildren." Good. "Do you think your grandchildren will be happy when you die, or will they be sad?" And she said, "Oh, they will be so sad." And then she looked at me and smiled and said, "Oh, I should get that pacemaker so that I can enjoy them a little longer and that they can enjoy me." Yeah. So helping them understand what reason for living is there, what meaning they have in their life.
And that's sometimes where we have to meet our neighbors, especially those that are non-believers. People that are non-believers, you have to look around them. What is it? What is it that where do they find meaning in life? And then little by little, when they see your person and when they see how interested you're on them, they're going to ask you, what brings meaning to your life? And that's when you would be given the opportunity to share Jesus. So hope. We're defining cope and hope because they're working dynamically together. And hope, like one of the presenters said, was kind of hard to define because hope is in the future, right? Hope is in the future. But in psychological literature, it's a yearning for amelioration of the dreaded outcome, right? I hope this doesn't happen, or I hope, for a cure. In theological literature, it's a virtue along with faith and charity, right? So faith and hope. Faith is not hope, but faith is a jumping start of hope, right? Or a spring. You spring from faith to hope. And it's a positive goal-related motivational state that you're in when you have hope. And in the nursing literature, it's described in 3 dimensions. In the nursing literature, hope is described as being, as something inside of you that remains positive. Also in the nursing literature, it looks at the person in doing. It's a dimension of doing and a dimension of becoming. Dimensions as it anticipates, as hope anticipates the future possibilities in whatever happens. Because it's hard to really define hope. And to have hope, then, is to acquire a belief in your ability to have some control over your circumstances. And in medical literature, you find all over the place for the physicians, it says that maintaining and restoring hope is an important function of a physician. But really for us, maintaining and restoring hope as Christians, right? within our church, within ourselves, is something that happens every day, especially when we have catastrophes as we see every day. But in Ephesians 3:20, we see that in the Bible it says, "Now to him who is able to do immeasurably more than all we ask to or imagine, according to his power that is at work within us," is something that tells us, where does hope start? 1 Peter 9:3, "Praise be to the God and Father of our Lord Jesus Christ. In his great mercy, he has given us new birth into a living hope through the resurrection of Jesus Christ from the dead." And then in Ephesians 1:12, "In order that we who were the first to put our hope in Christ might be for the praise of his glory." And the reasons why I share this with you is because usually we assume that we know that hope is fundamental to confront the seriousness of threats that come into our lives. But it is not automatically self-renewing. You know, there's people that think that hope is just self-renewing, that you have nothing to do with renewing hope, that it just happens automatically. But really, hope needs something to jumpstart it, where you start it, where it springs from. And it also needs something to jump to. So what that means is hope starts somewhere. Okay, and what I'm saying here is hope for us starts with Jesus, right? That's where it starts, and then what it takes us is to what's already resolved for us, which is eternal life. But for people that don't believe, they still have to have hope, right, to go on a day-to-day basis. Where does the hope then start, and when does it lead? My husband just described one. You know, I don't want to live. I don't want that pacemaker. What am I going to live for? What my husband did was spring the talk in this lady's head, where to spring her hope from, right? That if I have this pacemaker put in me, I will be there for my grandchildren, right? So it took her to being there for her grandchildren. And then once she feels better, then that hope springs into further, living her life, seeing her grandchildren grow, et cetera, et cetera. But for us, the belief that hope is something that is just there and it grows and grows, it doesn't. Because we know that despair, right? Sometimes you can be in such despair that it'll absolutely just about take away all your hope. So hope and coping have three types. We have three types of coping that work in tandem. Again, like I described earlier, it's emotion-focused, it's problem-focused, and it's meaning-focused. So when we are anxious about something, we problem-solve about it, and then we find new meaning. But hope is right in the middle of all this. You can't cope without hope, and you can't hope without coping. Coping is moving, right? And hoping is what gives you the strength, the energy, right?
I'd like to emphasize this particular model that you see here. We have to be focused, looking at our emotions, understand that they are there, the tears. We need to look at the problem. We have to focus on that also, and we have to focus on finding meaning. Now, when you have hope, and this is critical because you have hope that something is going to happen. And what happened to hope with that you were hoping? If you get there, what happened to hope? There is no more hope. Because you got there. So the thing is this, I'm hoping that I get cure of my disease. But if you focus into the curing of that disease, if you get that disease cured, what happened with the hope? It disappears. So you have to have a balance of everything to be able, when you get there, to say, where do I go from here?
And that's what we're going to discuss.
Okay?
Okay. And we'll see this concept developing a little further in a research study that I'll be reviewing. So challenges in adapting to achieve well are many. So we can talk here all day on challenges of adapting to achieve well-being, all kinds of challenges. But we're going to just discuss two. And these two are more common, or virtually any person going through a serious crisis will see these challenges. And the first one is coping with uncertainty, right? Wouldn't you agree? Even going to college will be accepted, the uncertainty, will I be accepted in the college? Or will I be able to go on the trip? We deal with uncertainty always. And when we're dealing with serious illness, of course, it's the uncertainty of when you first have the test, what is it, right? I'm going to the doctor because I'm feeling sick. I wonder what it is. We deal with uncertainty. And the second one that virtually any person goes through is dealing with a changing reality. Changing reality. What was yesterday is not today. And so we will see how we deal with this. We're going to discuss now a video that you partly saw yesterday. And this talks about uncertainty. It's a situation where we will see uncertainty working out, and we will have a discussion on this.
Before you play it, just be prepared to discuss the different issues that you will see in the video, okay? Okay, go.
Oh, first of all, every stressful situation involves uncertainty. Is something happening? When and what do I do? Then there's an appraisal of the seriousness of the situation. And then the individual almost always relies on statements about odds. So when you are told you have a bad disease, the next thing you do is, well, how serious is it? Then the next thing you do is, well, what are the odds of surviving if it's a bad disease, right? What are the possibilities? Because that there is where hope comes in. It invites hope. Looking at what the odds are for me invites hope. And hope underlines any effort to cope. You cannot cope without hope. So good odds gains a strong hold on hope, right? When you say, okay, you have cancer, but the cancer you have, 80% curable or 90% curable. 95% of the persons that have your disease, are fine. Then your hope is pretty easy, right? But when the odds are poor, when they tell you, like we have our pastor friend that presented the other night on his wife and her cancer, when they tell you it's terminal, then there's a reappraisal. The nursing literature says, that there's a reappraisal to personalize the little bit of odds that there could be, to create hope. So for example, a person's told, there's a case in one of these studies where a college professor, Harvard College professor was told, you have mesothelioma, and you are going, it's a terminal disease. Of course, being a very intelligent person, he said, what do you mean I'm going to die? I mean, where can I find more? The doctor told him, do me a favor. Don't go crazy. Don't read about this. Go put your house in order because this is a terminal disease. Well, being, a Harvard professor, he went to the library and he pored over all the articles and all the research done on this. And he said, that's true. This is a terminal disease. But there was 5% of people that have this disease that live longer. Not that live longer. So what this man was doing was reappraising, wasn't he? He was reappraising, okay, I fit, let me see now, do I fit in this 5%? Okay, so he said, oh, yeah, I fit in this 5%. And so therefore he reappraised, he gained new hope that because he looked at the characteristics of the people that lived 5% longer, he fit in that category. And so when he reappraised, he personalized it and he gained hope of at least living a little longer. We wanted to talk a little bit about grief and some research that has been done on grief. And this research was done at the Boston University. And this was done by a group of two social workers, Kelly and Chan. And what they did was they found that they found that attachment to God, meaning, and religious coping were mediators in grief experience. And you go, well, why is this research important? Well, because we do so much empirical research and we do so much stuff on science and on medications, but really what effects does God have? And we've been hearing throughout the conference about this evidence base on religion and really the relationship with God. So some of us have experienced this and some of us haven't, but here research tells us it does. So what they did is they sent out through to psychologists, funeral homes, etc. They sent out a call for participants of people that had experienced loss within the last year. And they had 100 responses back. And when they had the responses, they sent them a packet. And in this packet, they gave them these tools, these inventories. One was experiencing in the close relationship inventory, examining if these people had close relationships. They took another inventory on relationship with God scale. They took a coping scale. They also took an inventory on complicated grief. And complicated grief was those people that were really, really having trouble with grief, were really, were not coming out of the depression or were handling it in violent ways. And so that's what complicated grief was. And then also they took a depression scale and then a stress-related growth scale. A stress-related growth scale is an inventory that examined how people learned from what was happening. What were the people learning through stress? You know, when we have a bad situation happen, do you grow from it or, you know, do you not? And that's what stress-related growth scale measured. So the findings were as follows. Secure attachment to God predicted greater meaning and less depression, and it also predicts positive religious coping. They found that less depression and grief, this attachment to God, people had less depression and grief and had more stress-related growth. In other words, they learned from the bad experiences more than the people that were not attached to God. Attachment to God had the strongest relationship to meaning in the dimensions of purpose and coherence. In other words, articulating the event, articulating what was happening to their lives, articulating how they were dealing with it. Attachment to God had the strongest relationship to meaning. Parents that lost children find meaning in the loss after 5 years, they were well adjusted. The highest level of complicated grief, remember what I said, people that weren't dealing with grief very well, that were found in people that either did not find benefits in the loss or made any sense of the loss at all. So people that couldn't find meaning in what was happening, or people that even that just couldn't get past it, had the complicated grief. Wanting to find meaning and not being able to do so resulted in poor adjustment to the loss. So some people want to find meaning and they're just not able to. They were not able to, and the grieving was worse. So seeing through attachment theory, humans are biologically predisposed to seek security and comfort in relationships. We know that, right? We know that seen through our beliefs, God made us and actively seeks a relationship with us, right? So God made us to have relationships. We know that from the creation. So religious behavior reflects a dynamic attachment process to God as seen in a mother and a child relationship. And it maintains a sense of God's availability. So that's how this theory of attachment works, that it's like a mother attached to a child. When we believe in God and we're attached to God, we know that God is available to us, like our mothers are available to us. And that's how the theory is based. It offers something beyond, the religious coping offered something beyond the limits of this world. It's turned to in crisis. You know, the next day in Boston, in Massachusetts, after 2 days, there was a huge religious ceremony, prayer. The president came, President Obama and everything, to pray and comfort the people of Boston. We turn immediately to religion when we're grieving. Attachment to God is reflected in religious practices that can result in beneficial and some in harmful coping. Harmful coping could be people that take religious practices and start like maybe repeating, let's say, activities they do, like people that will pray without ceasing but won't eat. They say they're praying and they won't take care of themselves. Sometimes religious coping can be harmful as well.
I'd like to share another story, not story, but study. Dr. Randolph Bird is a physician and a cardiologist at the University of California in San Francisco. He took over 320 patients and divided them in 2 groups for the study. One group was going to be the control group. The second group was going to be the study group. He went out and chose people that like to pray for others. It's called intercessory prayer. And then he said, okay, I want you to pray for these people, but do not pray for these other people. Now, again, the names were in a sealed boxes, so nobody knew in which box they were. As they continue with the study, and for several months, people were praying for the study group. At the end of the study, when they unsealed the study, they discovered the following. People that were prayed for, people whose names were in the boxes that were being prayed for, after surgery, these are people that went through open heart surgery, by the way, I forgot to say that. After the surgery, those that were prayed for needed less antibiotics, less diuretics, and they had less respiratory complications than those that were prayed for. So we know that God has an influence in what's going on. Also, we discovered that people that had more attachment to God, that trusted in God more, were able to do better. Dr. Elizabeth McSherry from the National Institute of Health, when she was in Boston at the VA hospital, she had about 700 veterans that came to the hospital for treatment. She also did a different study in which she divided the groups in 2. One group was going to be with the chaplain and spend time with the chaplain about 15 minutes, half an hour every day. The other group was going to see the chaplain 5 minutes, only one time during their hospitalization. These are people that had suffered spinal cord injury. She discovered that those that were able to talk to the chaplain for for an hour or 2, several minutes every day, were discharged from the hospital because they got better 2 days earlier than those that only saw the chaplain for 5 minutes.
So relationships do matter. Now, meaning. Remember, this is the third mediator in grief. We talked about religious coping, and we talked about attachment to God. These were the biggest findings. The fundamental motivation of human beings is the will to find purpose and meaning. Humans construct frameworks of meaning by which to understand themselves and life, to generate purpose and to shape goals and expectations. And this was in Frankel's writings in 1984. But loss can profoundly disrupt or even shatter these assumptive frameworks, causing a crisis in meaning. And how many of you know about these people that we just talked about? Dancers that lose their legs, mothers that lose their children. It totally destroys and shatters their meaning. So grief involves reaffirming one's meaning system, or when this is not possible, reconstructing meaning in a way to assimilate that the loss that allows one to embrace the altered life. Post-traumatic growth or stress related to growth is closely related to meaning, and it initiates when meaning is disrupted following a loss, and it emerges as a new meaningful in life goals. God, in this study, the result at the end says, God may provide the ultimate source of meaning that allows people to assimilate a loss without feeling that their world has been threatened and shattered. So in this study, what they found was the higher attachment levels people had to God and their religious belief, they kept changing the meaning in their life, and immediately they found that as they coped, they found a new meaning. And they said, okay, so now I'm going to live for 2 more months, but I want to do this. I want the new meaning for me in this whole situation is this. I'm not going to do this, but I'm going to do this. And so this is very important throughout the healing talks that we have.
And I want to say that finding the new meaning, what you just said, it is so important. I cannot stress that. Finding a new meaning is so important. Viktor Frankl, in his book, Finding Meaning in Life, he talks about the concentration camps that he survived. And one of the problems they found is that some survivors, some people that survived the concentration camp, when they walked out of the concentration camp, they could not find new meaning for their lives. And they committed suicide after they were freed from the concentration camps. So that's important.
So it's not just for the moment, it's for the future. As we've been talking, hope not only is a place to spring from, but it's also a place to spring towards.